We're going to continue our discussion of gross anatomy and turn our attention to the abdomen. So we will be doing the abdomen, and we'll follow that with the pelvis and perineum. And for the abdomen, what we're going to cover first will be the abdominal wall, and that will primarily focus our attention on the inguinal region. So we'll do the inguinal canal, the descent of the testes, and then issues relating to inguinal hernia. We'll then turn our attention to the viscera within the abdominal cavity and start with the digestive system. And we are going to be doing the embryology of the digestive system, the development, and the congenital abnormalities related to that, right along with the adult anatomy of the digestive system. And then we'll conclude the abdominal cavity viscera with the kidney and the ureter. And again, we'll do the adult anatomy and the embryology of those organs side by side. So let's get started with the abdominal wall. The abdominal region is conventionally divided into 9 subregions, and the way we do that is by creating 2 vertical lines that correspond to either the mid-clavicular line, which is also the mid-inguinal line, on the right and the left side, and then 2 horizontal lines, one at the level of the subcostal plane, and which is at about the level of L3, and then another at the intertubercular plane, which is at about the level of L5. That divides the abdomen into 9 regions, with a right and left hypochondrium, a right and left lumbar region, and a right and left inguinal region. And as I said, we're going to be spending our time on the abdominal wall primarily looking at the inguinal region and the structures related to that. I also want to call your attention to the 3 midline regions that are termed the epigastrium superiorly, the umbilical in the middle, and the hypogastrium inferiorly. These 3 regions are going to become important to us a little later on when we're discussing the GI tract, because the organs of the GI tract, when involved in inflammation or any pain-producing phenomenon, refer their pain to the midline of the abdominal wall, and the regions of the midline, epigastrium, umbilical, and hypogastrium, will relate to the 3 portions of the GI tract based on the GI tract's embryology, specifically the foregut, the midgut, and the hindgut. So that pain arising from a, for example, midgut organ will be referred to the umbilical region, whereas pain arising from a foregut organ would be referred to the epigastrium, and so forth. So we'll come back and talk about that some more when we do the GI tract. So now we're going to talk about the abdominal wall so that we can then talk about the inguinal canal. Now, the abdominal wall is made up of 8 layers, and it's really important that we understand what those 8 layers are if we're going to understand the inguinal region. So we'll start from the outside and work our way in. The outermost layer, layer 1, is the skin. No surprise about that. Obviously, that's the outermost layer everywhere in the body. And then just below that, as you'd expect, is the superficial fascia. That's layer 2. Now, in the abdominal region, particularly in the lower abdominal region, where the inguinal region is found, the superficial fascia is divided into 2 portions, an outer portion and an inner portion. The outer portion contains fat, and so it's called the fatty layer, and you'll frequently hear that referred to as Camper's fascia. And that layer is of variable thickness from person to person, depending upon how much fat that person has in his or her abdominal wall. Just deep to that, there's a much thinner layer that has no fat, and so it's called the fibrous layer. And that's a fairly standard, constant thickness. It's a thin, fibrous layer without any fat, and that's also referred to as Scarpa's fascia. Now, just deep to that, we're going to have 3 layers, each of which has a muscle associated with it. It'll be the external oblique layer, the internal oblique layer, and the transversus abdominis layer that we're referring to here as layers 3, 4, and 5. Now, each one of those 3 layers has associated with it three components, three separate components found in each of the three layers. And it's the same three components for each layer, so we can just talk about it for one of the layers, but it will apply to all three layers. Each layer has as one of its components a muscle. So there's an external oblique muscle, an internal oblique muscle, and a transversus abdominis muscle. Then each layer has, in addition to the muscle, an aponeurosis. Now, aponeurosis is a tendon. It's just another name for tendon. It means it's a wide, flat tendon. And so this is no different than what we see in other parts of the body. Wherever you have a skeletal muscle, at the end of that muscle you have a tendon, in this case an aponeurosis. And the name of the tendon or the name of the aponeurosis is always going to be the same as the name of the muscle, regardless of where in the body we are. So in this case, since this is the external oblique muscle, at the end of that muscle there'll be an external oblique aponeurosis. In the internal oblique layer there'll be an internal oblique muscle and therefore an internal oblique aponeurosis and so forth. Thirdly, every muscle in the body is covered by a fascia, a deep fascia. And so the third component in each layer is going to be fascia. So the fascia always takes the same name as the muscle that it covers. So in this layer, the fascia covering the external oblique muscle will be called the external oblique fascia. And then similarly, we'll have an internal oblique fascia covering the internal oblique muscle and so forth. Now, not only does the fascia cover the muscle, but when the muscle ends and the aponeurosis begins, the fascia keeps right on going. So the fascia of the external oblique layer not only covers the external oblique muscle, it also covers the external oblique aponeurosis. And that's going to be true for the internal oblique and the transversus abdominis layers as well. There'll be a fascia, and that fascia will cover the muscle and the aponeurosis of the same name. So each of those three layers will have those three components as illustrated here, a muscle, an aponeurosis, and a fascia. The next layer, deep, layer number 6, is called the transversalis fascia. Now, the transversalis fascia, that's something different from the transversus abdominis fascia, so we should not confuse them. The transversalis fascia is a portion of a continuous layer of fascia that lines the entire inner surface of the abdominal wall, the front, the back, the sides, the top, the bottom, one continuous layer of fascia whose generic name is endoabdominal fascia, but in the anterior wall it's given the name transversalis fascia because it's directly under the transversus abdominis layer. So the fascia, the endoabdominal fascia, will take on the name of the layer that it's most immediately in contact with. So on the anterior wall, that would be the transversus layer. So here it's called the transversalis fascia. But remember that this is part of a continuous inner layer of fascia called endoabdominal fascia. We're going to skip layer 7 for one moment and come back to it and go to layer 8, which is the innermost layer. And layer 8 is the parietal peritoneum. That's the innermost layer of the abdominal wall. As soon as we get inside of that, we are going to be in the peritoneal cavity. So the innermost layer of the wall is the parietal peritoneum, just as we found in the thorax, the innermost layer of the thoracic wall was the parietal pleura. So it's the same concept. The innermost layer is the parietal peritoneum here. Now the layer just outside of the parietal peritoneum, the layer we skipped, layer number 7, is called the extraperitoneal layer. Extra meaning outside of the peritoneum, the extraperitoneal layer. Now the extraperitoneal layer in the anterior abdominal wall does not have very much in it of interest. It has a little bit of fat and connective tissue, a few blood vessels run through it, but nothing much else of interest. However, that same extraperitoneal layer, as we follow it around to the posterior abdominal wall, becomes very thick, has a lot of connective tissue and fat in it. It's a very thick layer. And embedded in all of that fat and connective tissue are many organs of the abdomen. Organs such as the kidneys and the ureters and the adrenals and the aorta and the vena cava and so forth. Now, among the organs that develop in that extraperitoneal layer is the gonad. So in the male, what we're saying is that the testis develops in this extraperitoneal layer of the posterior abdominal wall. We know that later in development, the testis doesn't remain in that position in the extraperitoneal layer of the posterior abdominal wall, but rather it migrates to the scrotum. So the obvious question is, what parts of this scheme of layers would represent the scrotum? And what the scrotum is simply an evagination of layers 1 and 2. The skin and the superficial fascia evaginate to form the scrotum. And in fact, the superficial fascia that evaginates has no fat in it, so the fatty layer is absent from the wall of the scrotum. So it's just skin and a thin fibrous layer. Now that fibrous layer we said was going to be called scarpous fascia in the abdominal wall. When it evaginates and becomes part of the scrotal wall, it changes its name and is called the dartos fascia, but it's the same fascia. So the scrotum is skin and superficial fascia, or dartos fascia. We said that the testis is going to be inside the scrotum, which means that the testis is going to be in this plane between layers 2 and 3. So that raises the obvious question of how does the testis get from layer 7, the extraperitoneal layer, where it develops, into this plane between layers 2 and 3? In other words, how does it do that? Get from here to there. And the process of getting from here to there is what is known as the descent of the testis. And the pathway that will be created as a result of that process is what we will call the inguinal canal. So the inguinal canal is going to be a pathway that gets us from the extraperitoneal layer into this plane just outside of the external oblique layer. Now, looking at this, we can see that there are 4 layers that are in the way. If the testis wants to get from here to there, we see 1, 2, 3, 4 layers that are going to be in the way. As it turns out, 2 of those layers, the internal oblique layer and the transversus abdominis layer, those 2 layers in the inguinal region are fused together. So we can consider these 2 layers as if they were a single layer. So now instead of saying that the testis has to traverse 4 layers, we see it's really going to only be 3. The transversalis fascia layer, the combined internal oblique and transversus abdominis layer, and then finally the external oblique layer. So that's the challenge for us. How are we going to get the testis from here to there? So in its migration, in its descent, the first layer that the testis will encounter will be this layer of fascia, the transversalis fascia. So the question is going to be, how does it get past that layer? What does it do about the transversalis fascia that's in its way? And as it turns out, what it's going to do is not really get past that layer of fascia, but rather it's going to evaginate that layer of fascia and pull that evaginated layer of fascia with it.